In this video, I'm going to be teaching you everything that you need to know about the pharmacology of hyperlipidemia and hypercholesterolemia. So this video is lipid-lowering agents, and it's brought to you by Dirty Medicine. Now, before I begin, very briefly, please consider signing up to become a Dirty Medicine member. So how this would work is on the homepage of my channel, you'll see this button depicted here by the red arrow that says join. You can also find this button on any of my videos, and in the description of any of my videos, you can find a direct link to sign up. Once you sign up and click join, you'll become a Dirty Medicine member. Dirty Medicine members provide financial support of the channel on a monthly basis directly through Google, so it's incredibly safe and secure, and it costs $4.99 a month. Now, in exchange for your support of my channel, you get some really cool perks. One is you get access to members-only voting. So right now on the community tab of my channel, I have an open poll for the next topic of my next video, but only members can vote on that poll. And the other cool perk is that anytime you comment anywhere on my channel, you'll get the little Dirty Medicine icon next to your name. So everybody who sees your comment will know that you're a Dirty Medicine member, that you support this channel, and that you are a believer of free quality medical education. So if you like Dirty Medicine, if you like the content that I'm putting out, you appreciate the free learning, then please consider signing up to become a member and give back to support my channel. Now, with that said, let's get into today's video. So we are going to be covering the different pharmacological agents that you see on this slide. So we're going over HMG-CoA reductase inhibitors, bile acid resins, ezetimibe, fibrates, PCSK9 inhibitors, and niacin. Now, generally speaking, these agents, these drugs, give medical students and other graduate health professionals a really tough time when it comes to studying. And I think, anecdotally, that this is probably the most requested video I've ever seen on my channel. There are constantly people asking for a video on this topic. And I started to think, why is it that this is such a challenging topic for med students? And the only conclusion that I could come to is that, first of all, there's really no good explanation out there in any resource currently that I'm aware of. There's not a lot of good mnemonics to remember the information that you need to know. And because all of these medications target different parts of the lipid or cholesterol pathway, it makes memorizing them pretty difficult. So my goal today is to simplify all of that information and condense it into an easily digestible lecture, which you can watch and feel confident that when you're done watching my video today, that you know everything that you need to know for USMLE and COMLEX. So I promise you that I will explain this better than anybody else, and buckle up because it is a little bit of a stressful topic. Now let's get started with the first category here. We're going to be starting with HMG-CoA reductase inhibitors. So these are also known as your statins, right? And an example would be atorvastatin, simvastatin. So these medications end with statin. The mechanism here is that, as the name implies, these inhibit HMG-CoA reductase. So it's kind of easy to remember on one hand because the name of the drug, or the name of the group of the drug, tells you its mechanism, right? HMG-CoA reductase inhibitors. And I think that it's likely that a lot of you are taking that name for granted. So let's go through the mechanism and use this to illustrate how this lowers cholesterol. So in the body, we need cholesterol. I know that everybody thinks of cholesterol as some negative thing, and certainly it can be when it's in excess. But the large majority of most of the cholesterol in our body is actually synthesized by our body in the liver. Remember, all cell membranes require cholesterol, so it's a hugely important part of our biology. So in the liver, in the hepatocytes, we have cholesterol biosynthesis. And in that pathway, you have this substrate called HMG-CoA. That HMG-CoA gets converted to mevalonate. And then downstream, that mevalonate will be converted to cholesterol. Now, the body is using this cholesterol, so it is a physiologically appropriate amount of cholesterol in the body. It's embedding it into different membranes, and it's embedding it into different processes throughout our body. The enzyme that converts HMG-CoA to mevalonate is HMG-CoA reductase, which you see here as in the step shown in blue. And this is the rate-limiting step in cholesterol biosynthesis. Now, when we give somebody a statin the statin actually binds to the active site of that enzyme, and it sort of makes it undergo this conformational change. Once the conformational change happens, that enzyme, HMG-CoA reductase, can no longer convert HMG-CoA into mevalonate, which ultimately blocks the downstream formation of cholesterol. So right off the bat, we're decreasing cholesterol synthesis within the liver itself. But how statins really truly decrease LDL is that in response to this action of the statin, you get a change on the hepatocyte. And I want to illustrate this by showing you the hepatocyte directly. So I want you to imagine that you have your hepatocyte here, and on the periphery of that hepatocyte, it has a normal amount of LDL receptors, which I'm showing here by those thick black lines. Normally, these LDL receptors will basically uptake circulating LDL and VLDL in the plasma. And what happens here is that when you give somebody a statin and you decrease the amount of cholesterol that can be formed internally in the hepatocyte thinks to itself, damn, I need more cholesterol. And the way that it does that is it upregulates the LDL receptors on its membrane and basically takes up more LDL and more VLDL, thinking that if it takes up more of those substances, it will be able to make more cholesterol. So the hepatocyte, which you see here on the left, which might normally have 4 LDL receptors, and I'm just totally making up that number, in response to a statin, it'll upregulate LDL receptors and therefore take up more LDL from the circulating plasma. And it's this secondary response to the statin that really drastically lowers LDL. So this is how statins lower LDL, and it's very, very important to understand. It's not just as simple as it's inhibiting HMG-CoA reductase, but it's the secondary mechanism where you get upregulation and increased transcription of these LDL receptors, which then flip out to the liver cell membrane, and once they're on that outer part, can take up LDL and VLDL out of the plasma, where they're endocytosing them back into the hepatocyte, and then that cholesterol component later gets broken down, recycled, excreted, etc. So this is how a statin works. It's not just that one mechanism. It has a lot of pretty profound effects. And for this reason, HMG-CoA reductase inhibitors, aka statins, are just the gold standard treatment of hyperlipidemia. So every patient, regardless of whether their triglycerides are high or their LDL is high or their HDL is whatever, it doesn't matter. You're putting them on a statin. Statin is the answer. It's very, very high yield to know that. Adverse reactions of the HMG-CoA reductase inhibitors include hepatotoxicity and myopathy, which I would be remiss if I didn't note that myopathy is worse when you combine a statin with either niacin or fibrates. And that point, for whatever reason, shows up on tests quite often. So know that you can get myopathy, but know that myopathy can be particularly severe if you're giving somebody a combined statin plus niacin or statin plus fibrates. And I have to note that HMG-CoA reductase inhibitors are one of the proven medications that will decrease mortality in patients with coronary artery disease. So a classic test question is that they give you somebody that has coronary artery disease, and they'll ask you which of the following medications should be given to decrease mortality. And the answer would be statin would be one of those answers because it has been shown to decrease mortality in these patients. Very, very, very high yield. So how do you remember all of this? Well, luckily the medication name tells you the mechanism. So that's not really hard to remember at all, because in your answer choices, if you see HMG-CoA reductase inhibitor, you know the mechanism. So really what you need to take away from this discussion and memorize are the adverse reactions, as well as the fact that this decreases mortality in patients with CAD. So my mnemonic for HMG-CoA reductase inhibitors is HMG. H for hepatotoxicity, M for myopathy, and G for good for CAD. Also, another way of saying decreases mortality in patients with CAD. So that's all you need to know about the HMG-CoA reductase inhibitors, aka statins. Let's move on to bile acid resins. So these agents you will see as cholestyramine, cholestyramine, and colesevelam. I'm probably butchering that last one, but who cares? The mechanism of the bile acid resins is that they interrupt enterohepatic circulation. And in order to understand this mechanism, we sort of have to go back to gastrointestinal physiology a bit. So recall that you have bile acids, and after the bile acids get secreted, they're in the intestine, and there needs to be an efficient way for the body to reabsorb all of these bile acids. Otherwise, it would be wasting a ton of energy constantly making them and excreting them. And if we were to sort of zoom in on the intestine, what basically happens here is that the enterocyte takes up those bile acids, and then ultimately the bile acids make their way back to the liver. And this connection between the intestine through the enterocyte back to the liver is what's known as enterohepatic cycling. And specifically, bile acids are involved. So this is the normal physiology of the enterohepatic circulation. But what happens when we introduce a bile acid resin? Well, the substance within this drug is positively charged, but bile acids themselves, shown in blue, are negatively charged. And you get the creation of this compound or this complex where it's opposite charge on one side, negative charge on the other, and because of that, it's impossible for the enterocyte to take back up the bile acids. So you're effectively knocking out enterohepatic circulation. So another way of phrasing this would be that you decrease bile acid absorption since it can't be taken back up, and you increase bile acid secretion because if it's not reabsorbed, it's excreted. So if we go back to our overview slide, it is correct to say that the mechanism of bile acid resins involves interrupting enterohepatic circulation, but on a more micro level, we might rephrase that as saying there's decreased bile acid absorption, increased bile acid secretion, which means that from the liver's perspective, the liver's like, oh damn, I'm not getting any bile acids back. It's time to make new ones. So increasing hepatic bile acid synthesis effectively uses up all of the cholesterol that's just chilling out in the liver. And when that happens, the liver says, oh crap, I'm using up all of my cholesterol stores. And as we talked about with the statins, the LDL receptor activity increases, which takes up circulating LDL out of the plasma. So you get an increase in LDL receptor activity and a decrease in free circulating LDL. And this is the mechanism by which bile acid resins decrease cholesterol. So we talked about the mechanism. The adverse effects that you need to know are GI upset and fat-soluble vitamin malabsorption. This should make a little bit of sense because this has to do with absorption through the intestine. And if you have all of that bile acid just sitting in your intestine, needless to say, you might be farting a bit. So that's bile acid resins. Now let's talk about ezetimibe. Ezetimibe's mechanism is that it inhibits the NPC1L1 receptor, blocking intestinal brush border reabsorption of cholesterol. No fancy breakdown here, just memorize it inhibits the NPC1L1 receptor, which is the receptor that reabsorbs cholesterol at the intestinal brush border. The adverse effect that you need to know is that you can get an increase of your LFTs. So ezetimibe is pretty simple. It's just one drug. It inhibits one receptor. It has one high yield side effect. So the way that I remember ezetimibe is ezetimibe, IB, for intestinal brush border. And that reminds me that when I'm taking exams, if I see anything about blocking intestinal brush border reabsorption, the answer is ezetimibe. And I can take that one step further and know that the specific receptor is that NPC1L1 receptor. So ezetimibe, remember the IB for intestinal brush border, and that is pretty much all you need to know. Now let's talk about fibrates. Fibrates are drugs like gemfibrozil or bezafibrate. So they have FIBR, fibr, in the name. So it kind of tells you that you're talking about a fibrate. Really, fibrates have two mechanisms, and both are very, very high yield. So we'll go through them one at a time. The first is that fibrates activate lipoprotein lipase, or LPL. And recall that the activity of this enzyme is to take your triglycerides and, among other things, split it into fatty acids plus glycerol. Now, LPL has lots of different activities within the body, and if you're looking at a schematic within a textbook or some review source, whatever you like to use, maybe Harrison's, it's going to show you LPL doing a lot of different things. But for the purposes of this discussion and to keep things as stupid and simple as possible, just remember that LPL basically breaks down triglycerides. The second mechanism of fibrates is that they activate something called the peroxisome proliferator activated receptor alpha, or for those of you like me who just want to memorize short and sweet acronyms, PPAR alpha. Now, PPAR alpha is not too complex, but I'm just going to go through it very quickly so you fully understand this mechanism. So PPAR alpha, once it's activated, basically leads to the synthesis of HDL. We're not quite sure how this works, but the literature does suggest that the activation of this gene creates or synthesizes HDL, or your quote, good cholesterol. So these are the two mechanisms that you need to know: activation of LPL and activation of PPAR alpha. Now, the adverse effects of fibrates are myopathy, and that myopathy is worse if you co-administer fibrates with statins. And then the really high yield one is that you can get cholesterol gallstones, and specifically that's due to inhibition of cholesterol 7 alpha hydroxylase. So I recommend not only that you know that you can get cholesterol gallstones, but be able to take that one step further and know that the specific reason why fibrates cause cholesterol gallstones is because they actually inhibit cholesterol 7 alpha hydroxylase. Very, very high yield. So how do you remember all of this? Well, when I think of fibrates, what I'm actually thinking of is primates, right? Because it rhymes, primates. And my mnemonic here is: a primate has the stones to act like a part of the human species. And what does this sentence tell you? Well, a primate, for fibrates, a primate has the stones, cholesterol gallstones, that super, super high yield adverse drug reaction, to act like a part of the human species. And aparta, PPAR alpha, reminds me of the mechanism. And oftentimes, if they're going to go after one of the two mechanisms of fibrates, they're going to go after the one that's PPAR alpha, because as you might imagine, when they write out answer choices A, B, C, D, and E, if you were sitting there and you saw peroxisome proliferator activated receptor alpha, you'd be like, what the hell are they talking about? And seeing that is pretty overwhelming for medical students. So the test writers like to go after it. So fibrates, primates. A primate has the stones to act like a part of the human species. That's going to tell you the mechanism, the drug we're talking about, and the highest yield adverse drug reaction. Okay, so that's fibrates. Let's talk about PCSK9 inhibitors. So these are drugs like alirocumab and evolocumab. And these are actually relatively newer agents. They're not that old, and they are awesome medications. So for a while, we kind of struggled to treat high cholesterol. You know, statins were pretty good. They were the gold standard. But then PCSK9 inhibitors came along, and the data has been overwhelmingly positive. So these work by inhibiting pro-protein convertase subtilisin kexin 9. And again, if you're like me and you want to just remember a stupid little acronym, PCSK9. And when you inhibit PCSK9, you prevent LDL receptor breakdown. So I want to I'm going to put an image on the slide that I showed you earlier in this lecture when we were talking about statins. So here's your hepatocyte, and on the surface of your hepatocyte, you have LDL receptors, which are shown depicted as those little black spokes. So normally, under normal circumstances, that PCSK9 comes along and it targets those LDL receptors and it cleaves them, just breaks them right off. So those LDL receptors are now gone, and therefore there are less LDL receptors that are available to take LDL, which would be free and circulating in the plasma, out of that plasma. So effectively, PCSK9 under normal circumstances would prevent you, or prevent the body, from being able to take LDL out and lower it. So if we introduce a PCSK9 inhibitor like alirocumab or evolocumab, which are actually monoclonal antibodies, then these drugs will inhibit the PCSK9, and therefore PCSK9 would not be available to destroy and cleave those LDL receptors, and more LDL receptors will be on the hepatocyte. And therefore, those LDL receptors can take up LDL out of the plasma, effectively lowering it and treating high cholesterol. So that's the very, very high yield mechanism of PCSK9 inhibitors. Adverse effects that you need to know, there are really two of them. The first are neurocognitive effects. So specifically, we're talking about delirium and dementia. And the second, myalgias. Okay, so two adverse effects, really, we break them down into neurocognitive, delirium, dementia, and myalgia. Nothing more that you need to know for PCSK9 inhibitors. Again, the name of the drug tells you the mechanism, so it's inhibiting PCSK9 and thereby preventing LDL receptor breakdown. That's it for PCSK9 inhibitors. Let's conclude this discussion by talking about niacin. So niacin, also known as vitamin B3, yes, it's used in high cholesterol. The mechanism, there are two. One, it inhibits HSL, or hormone-sensitive lipase, specifically in adipose tissue. The second, it inhibits hepatic VLDL synthesis. So not a whole lot of complexity here. It just turns off HSL and turns off hepatic VLDL synthesis. The adverse effects are really what you want to memorize when it comes to niacin. So usually, not always, but usually if a test writer is going to go after niacin, they're going after the adverse effects because they're very, very unique. You can see them here. The big one is that you get this flushing red pruritic appearance, and that's actually treated with NSAIDs. So the test writer might not tell you that the person has hyperlipidemia, hypercholesterolemia. You might get a set of labs in the question. You have to look at the labs, recognize that LDL's through the roof. And then if they tell you that the patient took an unknown medication and started getting this itchy red appearance, that you have to infer that they were treated with niacin. And the question might say, which of the following is the treatment? And you pick the NSAID. The other unique adverse effects are hyperglycemia and hyperuricemia. So these are high yield because you might imagine that you're taking USMLE or you're taking COMLEX, that a patient gets an unknown medication and all of a sudden they give you labs, you see a high blood glucose or you see a high uric acid. So you need to be able to pair the potential adverse effects within a lab printout with niacin. And that's why this is such a high yield topic. So know the adverse effects more so than the mechanism. That's niacin. That's really all you need to know. So the last slide, this is for your studying pleasure. This is the main target of all of these different agents. So if you look in, different review sources, different question banks, you go to internal medicine textbooks, they're going to have some table that's going to tell you what is the primary target of all of these different agents. And is that LDL? Is it HDL? Is it triglycerides? What's the main mechanism, right? What's decreasing or increasing the most? For whatever reason, this is high yield. So just know this. The way to remember this is to just memorize the exceptions. So the way that I suggest you go about this is everything decreases LDL with the exception of fibrates and niacin. Fibrates decrease triglycerides. Remember, they work through LPL, so they're cutting triglycerides basically. And niacin technically does decrease LDL, but it also increases HDL. So if you get a question and they want you to, talk about the major specific fat or the specific cholesterol that's changing, what you want to do is if it's not fibrates or niacin, the answer is LDL. If it's fibrates, the answer is triglycerides. If it's niacin, the answer is HDL. So that's how you memorize this. Don't waste your brain space pairing each one up to a specific thing. If you happen to know the mechanism and can take that one step further and say, yeah, of course, when this is happening as a mechanism, then LDL will go down. That's great. And I wish you really well in your nerdy academic career. But for those of us that have limited brain space, memorize your exceptions. Fibrates, triglycerides, niacin, HDL, everything else, LDL. So that's it. I know it was kind of fast, but that's what you need to know about the pharmacology of hyperlipidemia and hypercholesterolemia.